this concept that we have of patient experience, let's just be frank. To me, it's still a very ambiguous concept. So patient experience, we're all talking about it. In senior living communities, we talk about resident experience. But to me, patient experience, at its essence, is still a very ill-defined construct. I don't think there's consistent measurement around it. And it's still not understood at a very person-centric level. Of course, we have our HCAHPS scores in hospitals. We have our CMS star ratings. But at the core, what does it mean to have an exemplary patient experience? So that is the question that really led the research team in healthcare at Sodexo to explore the notion of fear and its alleviation as central to having a very good patient experience. Fear is universal, but the way we manage it is not. If you think about humans, we're not very good at really telling people what we need, are we? Sometimes we think we know what we need, but if you think about a conversation you've had either with a boss or with a spouse or a partner or a friend, sometimes you're conveying a message, but it may not be what you truly need. So to go back a little bit, who's taken a Psychology 101 course? And if you remember needs theory, this is where some of our work stems from. Also, if you come to Jungian theory, so Carl Jung talked about the universal collective unconscious. And so all of us, deep in ourselves, have these core needs for comfort, security, alleviation of fear, recognition, etc. So taking Sodexo, it's a global company in 80 countries, and we needed a way to understand patients universally. And so what we decided to do is we said we need to go to human needs theory to understand what's common to all of us. And in the hospital setting in particular, the one key thing that a patient needs to alleviate is fear. Albert Einstein, I think, said it very well. Hunger, love, pain, and fear are some of those inner forces which rule the individual's instinct for self-preservation. So let's take the concept of self-preservation. It's more really than just living. It's more than existing. It's existing with dignity, with meaning, with purpose, with value. Let's think about that in a hospital context then. What does self-preservation mean in a hospital context where that environment is so foreign to us? And so fear, while we deal with it normally in everyday life, it takes on a very different context in a hospital setting. What happens when fear goes wrong in a hospital setting? Again, let's just go back to our daily life. When we're anxious or afraid, how can fear go wrong? Think about that in your daily lives, in your daily work lives. But when you get to the hospital setting, a lot of these are familiar to us, right? So if a patient is afraid, the communication goes way down. People may shut down. They may not be able to speak in the language of the provider. They may not have the resources to communicate well with the provider. They may take up too much of the physician's or the nurse's time. If they're afraid, they may need too much information, or they may be asking too many questions or ringing that buzzer too often. Oftentimes, when patients are in fear, they can become irritable and occasionally violent, and we're hearing more and more of this. So fear is not just something that's interesting to study. Fear has very, very serious implications for improving the patient experience, but not only that, but helping the staff communicate with the patients and then subsequently achieving better outcomes. All right. These are the most common patient fears, and they're actually in order from the left going on down, from the Patient Empathy Project by Sweeney. And so I don't know if any of these are surprising to you, but number one, infection and germs, and then you're going downward. And again, these are things that people say they're afraid of, right? So they have to put something, they have to verbalize it. I don't think this captures everything. But if you see these and you see them placed in front of you, for those of you who have a research bent or who are very tactical, these are the areas where you start to concentrate. And you say, okay, knowing these areas, what can we do as service providers, whether we're healthcare professionals or we do support services, or we're a chaplain? How do we, knowing these, tailor our approach? Again, fear universally in any setting is very complex, right? But in the hospital, it's more so. And why would that be? I think we know it intuitively. But when we're in the hospital, we're literally stripped not only of our clothing, but of our typical resources. So how we exist in the world is not how we exist in the hospital by any means. So we've got the power differential between the patient, the provider, okay? Even those of us I know in this room may get a little bit stuck when we're talking to a physician. We may not be able to communicate as well as we might have in a normal day situation. So not only do we not have our identity as we are out in the world as a resource, or our power that we have out in the world as a resource, we may not have our social support ready. We don't have our things that make us comfortable around us, and we lack that sense of control that's so critical in our lives. So again, fear in the hospital setting is complex because our resources are taken away. So the flip message would be to give back the resources that people need to have one of their core need states fulfilled, which is comfort. Comfort, safety, security. How do we do that? Okay. One of the things, moving from the National Institutes of Health, which is this rigorous federal government entity with very tough scientific bents. I was a behavioral scientist there, and coming to Sodexo, I wondered how my scientific life would be affected, quite frankly. And I was pleased to see that whatever we did as research, we were able to translate. So we're a huge translational research organization. One of the tools we use is called Personics. And Personics is a way of understanding people better than you can do by just having their demographic information. So I may know your age, your race, your weight, your height, your ethnicity, your religious preference, your language. But do I know, based on that, how you behave and what attitude you might have towards something and your preferences? No, not often. So Personics is a psychographic tool, and in healthcare, we believe that the main need state, like I said before, that people are trying to take care of is fear. So based on that knowledge, we believe that people can be grouped in the hospital setting into 6 main types. And when you're in the hospital setting, you're not necessarily staying in one of these families. Your needs may change as to how you choose to alleviate fear. So let's talk about the axes, and I'm sorry they're a little bit dim. So if you look at the x-axis, when we tend to deal with fear, we either maintain on the left a very inward focus, so we may tend to get more quiet, turn inward. Conversely, we may reach out, which is on the right axis of the x-axis. Also, if you look on the y, you're either going to deflect the fear and push it outward, or you tackle it head on, which is a more, in our language, a more inward response. So again, you have the 2 axes. And then based on those, you have the 6 groups: self-centrics, attention seekers, minglers, acceptors, worriers, and loners. If you start to think about it, and I'm going to get into this in the next slide with more descriptions, the ability to categorize and understand people based on these categories has huge implications for how we communicate and tailor our care to them. I remember my father going into the hospital for pancreatic surgery. And there are a lot of us children. He has 3 kids. My mother is alive and taking care of my father, and he just needed so much information. And for the kids, it drives us nuts. So we'd all go see him, and he'd say, "When's the doctor coming in next? When do I get my meal? Did they clean yet? Did they do this?" And we're like, "Dad," but I wasn't realizing and taking the pause that that's not what I need, but that's what my dad needed to feel better and control of his situation and alleviate fear. So my dad, and I haven't told him this, but he's primarily a worrier. This tool is not client-facing. It's not patient-facing. So I would never tell a patient that they're a worrier, and I wouldn't tell my dad that he's a worrier, but it's helpful to understand that's how he's coping with fear. Okay. So now, I'm going to tell you a little bit more about these categories. And eat more kale is just a random message to you all today. All right. So if we think about these categories of people and how we want to tailor, think about the hospital setting and think about some of the services that are offered there, and there are numerous ones, anything from facilities management, some of the hard FM services, to softer services, concierge, patient ambassadors. Then you've got the training of the health professionals. So let's think about the people. If you're in the top left, it's about singularize my stay. They're very self-centric. It's all about them. The nurse may have 8 patients. That doesn't matter. So how can we convey that it's about them? And I brought this chair for a reason. So in one of our clients that we serve, in every patient room, there's a place for a chair to be hung on the wall. And as soon as the clinician comes in, they take it off the wall, they unfold it, and they come sit directly in front of the patient, introduce themselves. There's a protocol. And that one act, yes, has helped HCAP scores. I'm always delighted to know that it helps HCAP scores. But with authenticity, when this simple act is practiced, it tells a self-centric, or any patient really, I am listening to you, you are unique to me, and I value you. So there are visible behaviors that we need to see as patients, and this is a powerful one, getting at the level of the patient, speaking to the patient. Listen to me, attention seekers, very similar. So those folks might require some extra questions. Maybe this is something on a patient passport, say like Plaintree has, about their preferences in the hospital. This could be something done in the community with their physician. This could be done at other appointments, but how could we not only a little bit singularize their stay, but make sure their needs are met? Going into my bag, and again, so not only are we alleviating fear, but we're making them comfortable. This is my little friend, the lamb. So if you think about children and children's spaces, or even in the case where you can have healing animals in the environment, bringing in a sense of comfort, allowing some function where people can mingle if they can get out of their rooms is another way to take care of those patient needs. Again, what can we do to bring amenities to patients who are not too sick to receive them that bring comfort? I really like this lamb, but for others, it may be reading material, it may be their religious material of choice or book of choice. You just have to think what would bring comfort. When you go down to the loners, so on the far left category, they often don't want to talk much, right? And that can be hard. They want to be left alone. But in that case, it often provides people a lot of solace when they are alone to have the ability to journal or communicate in some other way. So whether it's letting them have a tablet, letting them have a journal that's provided, or reminding them to bring a journal, is powerful because it'll help get some of that emotion out, a bit of catharsis, perhaps having them write a little bit about what they're experiencing. So I really do recommend for all of these people, especially at the bottom, the notion of writing and any cathartic element that they can have. Again, worriers, they need a lot of information, and acceptors need a plan. So in this case, the checklists are invaluable, the precise giving of information as to when people should be anticipated in a room. Even the notion of visiting hours. I know that's not possible all the time to have, open visiting hours, but to let them know, okay, visiting hours are from this time to this time. Let's make sure your family's involved, etc. We're going to go more granular now to a specific service. Let's talk about cleaning, or infection prevention in this case, which is our #1 most common fear, right? And the implications of how we would communicate that to the 6 types of patients. So even self-centrics, right, with the do not disturb, I'm very aware that this is not really possible all the time in hospitals. But is there something we can give them to communicate that they'd like to sleep for a little bit longer, or they'd need to order their food now, or we can tailor something uniquely to them? What can we provide them that's under their control that will allow that? Cleaning people may often come in, it depends on how many times a day, and they can interrupt. So anything, again, to give them control as much as possible over that is great. Let's go to loners. They want to be alone. So how about a sign that just gives them, please knock before you enter? Just the control to put that on is valuable. Worriers, and I've seen this very often in hospitals now. I think hospitals are doing a good job, but the simple presence of a sign or wipes or anything that you have, or encouraging people to do hand hygiene, or asking their physician or nurse if they've washed their hands, or a simple sign that says, this room has been cleaned by so-and-so, is very powerful to alleviate some of that worrying. Even providing them with a simple sign that says, rooms are cleaned this time daily, this, is very helpful. And then acceptors. They need as much information as possible and in a planned form. So, that's just, I could talk about this all day. I was amazed about the lack of research on patient fear specifically and the measurement tools that are not available to me at this time to understand patient fear. So that is in the works, a measurement tool, because the only tools available to really measure fear deal with much broader fear concepts. Implications for communities. So one big takeaway here is I think that the way we bring up our children in terms of health education has got to be changed. So the implication I see here is really for a school system. So how can we change health education to be less disease-focused or issue-focused to how do you actually communicate with a physician or nurse? How do you feel free to not have the shame of talking about certain topics? How are you, as a young person, empowered to provide accurate information and true information to your provider? So I do see really neat things that could happen and really shift the way we teach people early on to be able to be better advocates for their own health. And with that, that's the end of my talk, and I look forward to talking to you all in the breakout session.